My name is Cadman Leggett, and I'm an associate consultant at Mayo Clinic in Rochester, Minnesota. On behalf of my co-authors, I would like to share with you our work on the diagnostic performance of volumetric laser endomicroscopy and confocal laser endomicroscopy in detection of dysplasia associated with Barrett's esophagus. Our work was done in collaboration with the Wellman Center for Photomedicine at Mass General Hospital. The use of advanced imaging technologies for the detection of dysplasia associated with Barrett's esophagus is a rapidly evolving field. In the present study, we compared two commercially available technologies, each with its own unique set of advantages for detecting dysplasia. Probe-based confocal laser endomicroscopy, or CLE, is capable of high-resolution imaging but is limited in its narrow field of view. Volumetric laser endomicroscopy, or VLE, is capable of wide-field cross-sectional imaging but with lower image resolution than CLE. The diagnostic performance of these two technologies has not been previously compared. We thought it would be important to do so in order to clarify the role of these technologies in Barrett's esophagus surveillance. In this study, we used endoscopic mucosal resection specimens as an ex vivo imaging platform. This allowed us to have direct imaging to histopathology correlation. We started by validating a previously published optical coherence tomography, or OCT, scoring index for the diagnosis of Barrett's esophagus neoplasia. The OCT scoring index uses criteria of signal intensity and glandular architecture to generate a dysplasia score. A greater surface-to-subsurface signal intensity and the presence of atypical glands are features associated with dysplasia. When the OCT scoring index was applied to VLE images of endoscopic mucosal resection specimens, we found a reduced diagnostic performance. We attributed this to the technological differences between OCT and VLE. We therefore thought it would be important to design a set of criteria for the diagnosis of Barrett's esophagus dysplasia using VLE. A salient feature identified in our VLE dataset was the presence of a mucosal layer associated with Barrett's esophagus. Mucosal layering is traditionally associated with squamous epithelium in VLE. However, we observed both partial and complete effacement of this mucosal layer in Barrett's epithelium. We found that samples with a partially effaced mucosal layer had lower signal intensity at the surface compared to the subsurface. This intensity profile was in part driven by the presence of the observed partially effaced layer. Although a lower surface-to-subsurface signal intensity would suggest that samples with a partially effaced mucosal layer were less likely to contain dysplasia, we observed that several of these samples were in fact dysplastic, especially in the presence of atypical glandular structures. Based on these findings, we decided to construct a diagnostic algorithm dichotomized by partial or complete effacement of the mucosal layer in Barrett's esophagus. We reserved the measurement of surface to subsurface intensity to areas with complete effacement of the mucosal layer and used the presence of atypical glandular structures to help us diagnose dysplasia in the presence of a partially effaced layer. It is important to note that atypical glands can also be found in samples with complete effacement of the mucosal layer, usually in the presence of increased surface intensity. I will use a case as an example to illustrate some of these features. A 67-year-old man with a history of Barrett's esophagus and high-grade dysplasia with no previous treatment underwent surveillance endoscopy. The endoscopic view shows two tongues of columnar mucosa. The tongue located at around 12 o'clock has a maximal extent of approximately 1.5 centimeters. The tongue located at around 5 o'clock has a maximum extent of approximately 2 centimeters. An area of nodularity was observed in the proximal portion of the tongue located at 5 o'clock, as shown in this image taken with narrowband imaging. In vivo VLE imaging was performed. We can observe the gastroesophageal junction as we are moving into the Barrett's esophagus segment. The tongue located at 5 o'clock is marked between the black lines. The tongue located at 12 o'clock is marked between the red lines. In this area, we observed two normal mucosal glands marked by the black arrows and an atypical glandular structure marked by the red arrow. This atypical glandular structure is potentially a mucosal gland, but could also represent a dilated submucosal duct. In the 12 o'clock segment, we note complete effacement of the mucosal layer with an area of greater surface to subsurface intensity as shown by the black arrow. This area is concerning for dysplasia. This area shows a partially effaced mucosal layer marked by the black arrow. Note the difference between the partially effaced layer and squamous epithelium observed at the 12 o'clock position. This area also shows several atypical glandular structures marked by the red arrow, suggestive of dysplasia. This area corresponds to the nodularity observed with narrowband imaging. An endoscopic mucosal resection of this area was performed. This video shows VLE imaging of the endoscopic mucosal resection specimen. Again observed are features of a partially effaced mucosal layer with several atypical glandular structures. CLE imaging was then performed. We used a topical fluorescent dye called 2-MBDG. Previously published criteria suggest that intense intracellular fluorescence, heterogeneous cellular sizes, and disorganized cellular architecture are features associated with dysplasia. This video shows several of these features, including intense intracellular fluorescence within glands and heterogeneous cellular sizes. By directly comparing the diagnostic performance of VLE and CLE using their respective diagnostic criteria, we found that the use of the VLE diagnostic algorithm achieved the highest diagnostic performance for detecting dysplasia. This is important because as technologies evolve, diagnostic criteria need to be optimized. Future studies will focus on in vivo validation of the VLE diagnostic algorithm. We are also interested in determining whether technologies such as CLE and VLE can be used complementary to enhance the detection of dysplasia. Thank you for your attention.